The 24-hour urine test for VMA or vanillamandelic acid and HVA homovanillic acid measures metabolites of catecholamines like epinephrine, norepinephrine, and dopamine. It's most commonly used to diagnose catecholamine secreting tumors such as a pheochromocytoma, neuroblastoma, and certain adrenal or sympathetic chain tumors. Because catecholamine release can really fluctuate, a 24-hour collection gives a better picture than spot testing. Elevated VMA or HVA levels points towards an increased catecholamine metabolism, and it warrants further imaging or endocrinologic evaluation. You can see that VMA and HVA are the major end products of catecholamine excretion in urine. Catecholamine metabolism is excreted in the urine. Elevated levels, therefore, can help confirm the presence of rare tumors, a ganglioneuroma or a ganglioneuroblastoma. These tests can also be helpful in monitoring disease recurrence after surgical removal. It's important to avoid certain foods and medications before testing caffeine, vanilla, and some antidepressants, as they can cause false elevations. Always also pair lab interpretation with clinical presentation, such as episodic sweating or high blood pressure. And this is kind of showing the process here. Beyond kidney function, there are certain urinary tests that reflect bone metabolism because the kidneys excrete markers of collagen breakdown. This can help to provide insight into bone reabsorption, and measuring urinary bone turnover markers helps evaluate diseases like osteoporosis, Paget's disease, and metastatic bone lesions. These tests are also used to monitor response to therapy since bone markers often change earlier than bone mineral density. The next few slides will review two of the most clinically relevant urinary bone markers, which is deoxypyridinoline and N-telopeptides. So deoxypyridinoline, or as I'm going to refer to it, DPD, is a cross-link of type 1 collagen that provides tensile strength to the bone matrix. It's released into the circulation during bone reabsorption and excreted unchanged in the urine, making it a direct marker of osteoclastic activity. The second morning urine specimen is preferred to minimize variation. Elevated levels indicate increased bone turnover, as seen in osteoporosis, hyperparathyroidism, and bone metastasis. Because DPD is also present in dentin, sample contamination with saliva can cause false results. So proper collection is key. Increased urinary DPD levels occur in conditions where accelerated bone breakdown. Examples could be postmenopausal states, osteoporosis, osteolytic metastasis, Paget's disease, multiple myeloma, and long-term corticosteroid therapy. They also rise in endocrine disorders such as hyperthyroidism and Cushing's syndrome. Elevated values in children reflect normal bone growth rather than a pathologic state. Measuring this value gives us a window into bone metabolism, which can help identify patients who are at risk for fractures and also tracks the effectiveness of an anti-resorptive therapy. Our N-telopeptides or telopeptides or NTX are another breakdown product of type 1 collagen that's released during bone reabsorption. Like DPD, they correlate with bone turnover and inversely with bone mineral density. NTX is particularly useful for early assessment of treatment response, as changes can be detected within 3 to 6 months compared to the 1 to 2 years required for DEXA scans. Elevated NTX levels are seen in the same conditions as DPD: osteoporosis, metastasis, hyperthyroidism, and bone diseases with high turnover. The reference range varies by age as well as by sex. We'll come back and we'll talk about our urine human chorionic gonadotropin or our pregnancy test.